the nasofacial groove, then it is the alaflaring. Nasofacial groove, okay, then this is the alaflaring, and this is the quarter view, oblique view. Okay, so when you get a oblique view, then this side cheek is full and this side is 1/4. That's why we call the 3/4 view. 3/4. Okay, so we confirm these finding in this view, and we can better comment on the LR status in this and the projections. Okay, so basically this patient have a complaint of the bump on the nose and some droopiness of the nose. Functionally he doesn't have much complaint. Okay, so just we follow the 7 golden step like morning in our class we discussed. In 7 golden step, what is the first step? What is the first step? Infiltrations. So in infiltration, what important steps? 5 important steps. Yes. First in the septum infiltrations. Second is the for the transcolumella incision, and third is the for the marginal incision, and fourth for the dorsum, and fifth for the yes. Okay. Cold saline देना. Cold saline. Yeah. What is the position of the patient right now? Position of the patient, that the head that should be little bit raised. Okay, 30 degree. नीचे और लगा देना. थोड़ा सा. थोड़ा सा. Yeah, always like the 80, 90, 80, 90. That is good always. Hypotensive anesthesia. Okay. So I already infiltrate, but just for the demonstrations, we infiltrate the cold saline. Okay, this is the cold saline. So usually we use this 5 ml needle, 5 ml syringe, and this 26 gauge needle. Okay, so just like when you do the septoplasty, then we infiltrate, but rather when you infiltrate, then like that, rather than the blanching, you have the you have a good ballooning. Look that, just like so. Along the line of your incision, sometimes if you use like the hemitransfixation incision or the Killian's incision. Okay, so you infiltration from the anterior to the posterior part properly. This is the first step of the infiltration. Okay, now for the second step of the infiltration, look that you just hold like this, and from tip defining point to the anterior nasal spine like this. Look that you can appreciate my needle, and then just like okay, and then between the tip defining point like this, and then in this vestibular scheme. And after the infiltration, by your index finger and thumb, just to do massage it, just for dispersal of this local. बेटा उधर का गेट बंद कर देना. Okay, so this is the second step. Okay, now for the third step, you need this instrument. How you hold this one? Like you just evert like this. Okay, like this, like this, and this is the soft triangle area. So like this. Okay, and then like this on both sides, like this. But the important thing, where you infiltrate. So how you identify for देना. So you just palpate it. How? Like you give the counter pressure, and then you find something here. hard structure. You feel that you find something hard structure here. This is the caudal margin of the lateral crust. This is the landmark. Sometimes some patient have a very flimsy or weak. You can feel on this side when you weak lateral crust. When you weak lateral crust, you feel here this one. Okay, this is the caudal margin of the lateral crust. If you have a weak lateral crust, then ideally the junction of the hairy and the non-hairy skin. Okay, now this is the third step. Now what is the fourth step? For the dorsum. So where we engage this needle?
Between the this upper lateral and lower lateral.
Yes. So look that. Look, Dr. Murtazal. This is the upper lateral. Okay. This is the upper lateral. Can you see it? This is the upper lateral. This is the lower lateral. So just look that. Once you pass like this, and then because this patient have a bump already, so just on either side, and we lift up this skin, otherwise needle comes like this. Okay, so we lift up it and just like this, and then on either side, not exact on the midline. Got it? And same on this side. Look that, you appreciate, this is the upper lateral cartilage. This is the upper lateral. Okay, so in like in endonasal rhinoplasty, this is the junction. So we make the intercartilaginous incision in this area. Okay, so like this, just we lift up it like this. Okay,
So this
बस locally दे देना.
nasal hairs should be cut, or we can do.
You can do, I usually not, but you can trim it. You can trim it like after the infiltration. You can trim it, so just you have a time for the hemostasis also. You can do it. And the last, that is the for the lateral nasal wall. So look that, this is the infratrabinate. Okay, this is the infratrabinate. So just lateral to the anterior end of the infratrabinate on lateral nasal wall like this. Just this is the anterior end of the infratrabinate. Okay,
So this is for osteotomy side.
this is for osteotomy. Just I for the demonstration, otherwise for osteotomy, at the time of the osteotomy we usually infiltrate. Okay, Udena, I just infiltrate little bit local because lot of time just for this. So this is the first step of first golden step. Okay, you can pack also for the sometimes. Okay, now what is the second golden step? Opening of the nose. Okay, so opening of the nose. So like again we use two incision, transcolumella incision and the marginal incision. So for the transcolumella incision, first usually we use 11 number blade marker दे देना. First usually we use transcolumella incision and then the marginal incision. The reason behind that, because the rest of all incision is under our exposure, and ultimate we use this transcolumella incision is the inverted V incision in the broken line manner. Why? Just to reduce the scar contraction. So you clear all these things in mind. Now the third, the site. So how you decide the site? So this is the best way. You hold your nose. Okay, this is the apex of nostril. Got it? And this is the base. Okay, the common mistake done by beginner, they mark from this to this. Okay, because this is the tip defining point on either side. Okay, and where this tip end, and the dorsum start, that is the supratip brake, and when the tip end and the columella start, that is the infratip brake. Okay, so this is the tip lobule proper, and these are the ala, this is the columella, this is the nostril. Okay, so yesterday we discussed all these things in the class. So just we mark mid nervous part. So just we make it dot like this, and like this. So this is the inverted V. Okay, now this is the inverted V, and then this is the horizontal limb of this, just like a W. So the distance between these limbs, that is around 3 millimeter, and the angle between this and this is around 60 degree. So it's a type of a W. Got it? Now just 1 or 2 millimeter behind this. This is the interior part, and 1 or 2 millimeter behind. Okay, and same on this side. Now yellow. So this is the knife, 11 number blade. So look that if you hold your knife like this and like this is the wrong method. Just perpendicular to the skin, and not like this saw like motion, just the step like this. Look that, but I firmly hold this one. Okay, I firmly hold this one, and just, yes, nothing. Got it? Now on this side, yes, leave it. Now this is the 15 number blade. So again, the important thing, like if you make an incision like this, then this is the wrong method, because maybe you have accidentally damaged this structure. So you should be lateral to medial, like this. Okay, and like this, and then just where we mark. Okay, and then like this. So we complete the transcolumella incision. Now this bleed from the which vessel? That is the branch of Cotridena, superior labial artery. So this is the disadvantage of the open rhinoplasty. This is the disadvantage of open rhinoplasty, that sometimes we damage the blood supply due to this injured of the vessels. Now you need the sharp scissor like this. Okay, and then we pass from this side like this to contralateral side. But if you feel the resistance, then you go from the contralateral other side. Okay, and then you ask your assistant if I am the right or wrong. Okay, if you push it forcefully, then you create a false passage. Okay, then now look, like in our video, now we have the support of the seizure. Okay, and you also check one more important, sometimes we enter in the margin of the medial crust. If accidentally you damage, you never panic, because sometimes in the beginnings, and when you have a long medial crust or the weak medial crust, then you can injure. So just we cut it. Okay, and now we need the next two important instrument. So you observe each and everything in the first case, like this is the single loop. Okay, so now one, put it like this, you hold this one. Okay, and this is the small white double prong retractor, so we put this like this, and this is not like this and not like this, should be just perpendicular like this. Okay, then what is the next important step? First you identify the margin of the medial crust. Okay, margin of the medial crust. So how you identify the margin of the medial crust? वो दूसरी वाली सीजर देना. By the seizure. Then how? You hold this seizure just a pen holding position, just like pen holding position, and then just like this, and then like this. You hold this and you feel just like a pen. No, but your curvature is towards like this. This is the important. When you hold the instrument, then you think learn. So you feel,
Yes.
yes. You just hug with like this. You actually feel, okay, this
Okay.
is the right side margin of
Yes.
the medial
Yes.
crust, and you just hold this one, and you just feel this one. Okay, this one. Okay, this is the, so first we secure the margin of the medial crust, we don't have any injury. Okay, now for further dissection, you never pull is too much other, because this one is a long medial crust, so sometimes the injured, ये यहाँ पे लगाओ. Yes, ये ऐसा लगाओ एक बार. Yes, yeah. So look that now this is the margin of the lateral crust. We sprayed it, and this is the soft triangle area. So like yesterday someone asked how can we prevent the injury, so you just little bit cut, not big chunk of the tissue. Okay, आप section ले लो, आप section करते रहो आप इसमें, and this should be on exact on the midline. Okay, midline, and then again just we sprayed like this, and then we cut like this. Now the important thing, common mistake by beginners, they do like this and they enter in this. So direction is towards like this. Okay, this should be on exact on the midline. Never go on upside. And then how much you go laterally? At this 2/3. Okay, then same on this side like this. Marker है, marker है. So look that this is the margin, this is the margin. Okay, this is the soft triangle area. So just we spread it, not too much. Okay, if you have an injury in the soft triangle area, then you have a notching later. So we complete the marginal incision and the transcolumellar incision both. Now because this instrument is used for infiltration and these both for the marginal incision. Now three important instrument we use later one like this, wide double prong retractor like this, and two small like this. You hold this one, okay, and others wide double prong retractor लगाओ like this. So this is the classical 3-point traction technique. Got it? We need little bit more exposure on that side. Okay. So now we expose this soft tissue envelope from the lateral crust. So the important thing, what is the plane of the dissections? Ideally, the plane of the dissection in our Indian scenario, because we have very thick skin patient, suprapericordial. Then how you find the plane? Like we have this white surface and you have this instrument. This is the Kakir periosteum elevator. So just like this, and same on this side. If you not forgetting the plane, you just make a plane like this, and then you have a very beautiful white plane. Okay, now ये बीच में होना चाहिए, and ये ऐसे भी नहीं होना चाहिए, ये ऐसे होना चाहिए. Like look, the things are changed when you have a like then but look that the things are changed. Okay, so then we cut. What is the name of this structure, Murtha doctor? Pitangui ligament. This is the dermocartilaginous ligament, because this dermocartilaginous ligament attaches this cephalic surface of the lateral crust with the dermis. Okay, so we just cut it like this. Okay, now we change the instrument this one. Okay, how? We go more near. When you go more near, then you can enjoy more better surgery. Look that we again find the tissue. Okay, and you never like this, otherwise you struggle. Look that now is the change. So the counter traction is very important. Like we cut it. Okay, and then this is the instrument. So now you do like this, like this, like this. No bleeding, otherwise you have a bleeding. Okay, and just go like this, like this, like this. What is the upper limit of the dissection?
Intercanthal.
Intercanthal line. Okay, and Manish, what is on either side?
1 centimeter.
1 centimeter. Okay, so where is the intercanthal line you mark? छोड़ दो इसको तो. Where is the intercanthal line? You can mark. Where is the intercanthal line?
On the here.
Yeah. So look that. Something when you do, then you learn the things. This is the medial canthus. Okay. This is the medial canthus. This is the medial canthus. This is the intercanthal line. Both of the medial canthus. This is the intercanthal line. Okay. Like yesterday we discussed, this is the glabella. Okay. This is the radix, root of the nose. And the deepest point in this radix, that is the nasion. Okay. This is the nasion. So we expose the upper limit, that is the intercanthal line. Now put the self retaining. we should know now what is the next step. What is the next step now? Because we expose the lower lateral cartilage, we expose the upper lateral cartilage, we expose the bony pyramid. Now
lateral exposure हो गया क्या?
lateral exposure हो गया, you check it, you check it. lateral exposure हो गया, you check it.
फिर ये जैसे यहाँ से ना सर ये थोड़ा ये
हाँ,
क्या ये टिश्यू है या फिर ये अलग है?
ये मैं बताऊंगा सर.
हाँ
अभी फर्स्ट वी एक्सपोज,
ओके
देन
सर
फिर डिटेल एनाटोमी डिसेक्शन
राइट
करेंगे अपन.
सर
बट लुक दैट लेटरली यू, इसको आप देखो,
जी सर
ये देखो आप.
ओके
ओके,
इंस्ट्रूमेंट 1 सेंटीमीटर
यस,
जाना
हाँ,
चाहिए
1 सेंटीमीटर जाना चाहिए दोनों तरफ. ओके, दिस इज द सेल्फ रिटेनिंग, दिस इज द सेल्फ रिटेनिंग डोर्सल रिट्रैक्टर. दिस इज गुड. सो हमें पकड़ने की जरूरत ही नहीं है. ओके, now we want to expose the septum. How we expose the septum? We need these two instruments.
So we go between these lower lateral cartilage. Maybe
Yes, lower lateral cartilage. So just these are the good forceps because they have a good serration. Now we hold like this. Okay, we hold like this. Hold, Dr. Murja, is this one, and this one. But how you hold? Like this. If you do like this, then you will not enjoy in the surgery. But if you hold like this, you can enjoy. Okay, you hold this scissor, yes, and then you cut this structure. What is the structure? This one, because you missed your yesterday class. This is the interdermal ligament. So you cut this interdermal ligament.
right from here.
No, how you cut it? You hold this one. You come on this side. No, on this end.
Left. Okay,
Yes,
left hand.
yes. नहीं, ऐसे नहीं पकड़ना, ऐसे नहीं पकड़ना, ऐसे, ऐसे. ओके, यस, यस, यस. यू लिफ्ट अप टिप लाइक ऐसे. ठीक है, आपने अपना लिफ्ट अप किया. ओके, बहुत ज्यादा नहीं है. ओके, नाउ टेक द सीजर. यस, सीजर शुड बी स्ट्रेट लाइक दिस. देन यू स्प्रेड इट एंड कट इट. स्प्रेड करना है थोड़ा सा टिश्यू एंड कट करना है. यस, because scissor sharp है तो spread it and cut it, spread it and cut it. एक चीज है, कभी भी सीजर है ना, ऐसे 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 नहीं चलनी चाहिए. लुक दैट, लाइक spread, spread and cut, cut to cut. Okay, now cut to cut, not like this. Okay, because when you do more and more, then you develop the thing. And your direction of Dr. Murja, not like this, always on the anterior inferior. The things are changed. Again you find हमें ये मैट चाहिए. हमें ये मैट अगर नहीं होगा तो आप एंजॉय नहीं करोगे. लुक दैट, अभी मैट आएगा ही. When you have a mat, then you enjoy the surgery. So that should be on the anterior inferior direction like this. This is the packed thing. पकड़ो आप. You can either you can come on this side, you go on that side, you come on this side, you come on this side. Now you hold, you come, you come, you hold this one, yes, and just take this scissor and spread it slowly, slowly, yes, and cut these tissues, yes, spread it, and your finger, this is put here, ऐसे रखो, yes, because this finger balance your scissor. Yes, spread it and cut it. Yes, yes. Slowly, 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 slowly. Yes. So now what we want to identify?
Dome of septum.
Yes, we want to identify the anterior septal angle area. So you keep, this is the glimpse of the,
Yeah.
okay, this is the glimpse of. So once you find this one, then how you do further? Just like you change your film. पहले हमने यूं पकड़ा था, look that, है ना? Now just hold like this. पकड़ो आप मेरे जैसे. Change हुआ, okay? And then just again you hold this scissor just in a pen holding position, like because we want to identify the plane, okay? You can, so this is the septum, okay? Now on this side, इसको मुकेश वो लगाओ, retractor थोड़ा सा. Just hold with this one. This is the advantage of this forceps because this is not injured the cartilage. Cartilage holding forceps है. And then just okay. So this is the anterior septal. What is the further step? What is the further step? हमने 7 golden step में क्या discussion किया था? We want to expose the more. हमें exposure चाहिए. No, 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 no. First हमें पूरा exposure चाहिए. So we separate the upper lateral and the septum. उससे पहले मैंने क्या बताया था? We degloving the mucopericardium on this upper lateral down. Sharp instrument देना. So look that first, like just we hold this one and look. Can you appreciate my instrument? Okay. So what I am doing, I am degloving my mucopericardium on under surface of the left side upper lateral cartilage. Okay, and then same on this side. Slowly, slowly. Okay. Now 15 number blade. So just this separate on this side. Yes, we have the now more exposure. Lateral crural retractor. These are the self-retaining lateral crural retractor. So now everything in front of you. Complete. Now first you check either you are in the right plane or not. So how we check it? Like this is the septum, okay? Because this is the common mistake done by the beginners and the patient have a lot of bleeding. So look that just make just by a posterior end of this one and just you check the things are changed. Look that this is the ideal plane. And when you are in the ideal plane, then ये सेक्शन करना है, ये जस्ट सेक्शन करना उजिंग कहाँ से. So just like now you have a white plane. Okay,
Yes.
on the another side, same by this, because you just go the subperichondrial. Okay, like this, by back end of the knife, things are changed. Things are changed. Otherwise, you have a bleeding. Look that. No bleeding. You enjoy in the surgery. Very good plane. So first, we know that what is your ideal plane. Okay. छोटा सा इधर को लगा दे cotton का patty. If we have the bleeding, maybe we are not in the right plane. Either मैं हूँ, आप हो, कोई भी हो. Otherwise, bleeding नहीं होती surgery में. You can enjoy. And then if you have the bleeding, then you can put like this and you enjoy your surgery. There is no bleeding.
The simple NF food or something is used.
Ha, this is 2 ampule of the adrenaline. We keep in one tray. Okay, in the one tray. Now, what is the next step? Yesterday we discussed after the exposure of the septum when we deglowing the mucopericardium. What is the sequence? Yes, good, very good. Look though, just like a cross like this. That means first you just go the posterior inferior, then posterior superior, and then the last the anterior inferior. Okay. So now we are in the right plane. You can use either the periosteum elevator, you can use the Killian's nasal speculum like just. Sometimes if you have a spur, then you can use that. And on the same on this side, ideally you can use the Killian's nasal speculum. Okay. Nasal speculum. Suction. And you should have this long bladed nasal speculum, because sometimes when you have a short nasal speculum, then you sometimes have a injury in the flap. If you have a oozing, if you have a bleeding, then you put a pack. Okay. Now we just expose this anterior most part of the caudal septum. हो देना. Tooth forceps and sharp scissor. Yes. Put it like this. These are the depressor septi nasal muscles. Yes, नीचे लगाओ. Now our exposure part is complete. Each and everything in front of us.
Inferiorly कितना करना होता है इसको ये वाला part?
Inferiorly कितना करना होता है? It depends. Suppose this part is okay. No need to the modification. तो हमें ये सब कुछ करने की जरूरत नहीं है.
और जो anterior जो nasal spine है वो तो इसके नीचे रहेगा ना? Every time no need to expose.
ये अगर हमें इसको मॉडिफिकेशन करना है तो हमें इसको एक्सपोज करेंगे, ठीक है ना। मुकेश पैटी डाल, 1 मिनट आया मैं। लाइव चल रहा है, देखो ठीक है। ग्लाउड। So now our second step is complete. Exposure is complete. So this you should be have such type of good exposure. Everything in front of. Now we just check the little bit anatomy, because like yesterday we discussed that nose consists by 3 parts: upper 1/3, mid 1/3 and the lower 1/3. Okay, upper 1/3 that is consist by the nasal bone and the surrounding important attachment. Marker चल नहीं रहा तेरा. So look that when you feel like this is the right side lateral nasal wall, okay, and this is the left side lateral nasal wall, okay, and just almost this is the nasal bone, this is the ascending process of maxilla, okay, on either side. And if you come, because you have to know this outer important landmark, and this T-sept cartilage, that is the upper lateral cartilage. When you just check inside, look that this is the upper lateral cartilage. So this is the upper lateral cartilage, and the lower 1/3 that consists by a pair of LR cartilage. Okay, self retaining लगाओ, self retaining लगाओ, मॉप करने का दो. So this is the right side LR cartilage, this is the left side LR cartilage. Okay, this LR cartilage have the 3 parts. Okay, the lateral most part, that is the lateral crus. Got it? The medial most part, that is the medial crus, and the part connecting this medial and lateral, that is the intermediate crus. Okay, that is the intermediate crus. This medial crus have the 2 part on either side. This is the foot plate. Okay, and this is the columella part, this one of the medial crus. Okay, and this part from this to this is the intermediate crust. So intermediate crust again have the 2 part. This part, that is the domal part. Okay, and this is the lobular part, and this is the dome junction line, This is lateral crus. Okay, this lateral crus is the widest part of the cellular cartilage. Like in lecture we discussed, it gives the maximum volume. Okay, वो लगाना ना ना ना, यहाँ पे इसको ऐसे लगाना है बस. मेरे को एक बार सीजर देना, शार्प सीजर देना. Now this lateral crus has the two margin. This is the caudal margin. This is the cephalic margin. Okay, this is the medial end. This is the lateral end. Like yesterday, you asked me regarding the scroll area. Look that when I pull it, then you find something. Marker dena. This is the scroll area. Now you hide the scroll area. Okay. So now you clear. I think when we do the cephalic trimming, then we never injure because we cut it and we split it. We never injure because mostly beginner friend think when we do the cephalic trimming, then we injured. Okay. So this is the scroll area and this is an important landmark for the marginal incision. Okay. This is the superior surface. This is the inferior surface. Okay. And this is the dome part and these are both are the dome defining points. Tip defining points usually fall on this line. Okay, lateral crura retractor लगाओ. This is the septum. This is the superior part of the septum, dorsal part of the septum. This is the caudal part of the septum. So the angle between the dorsum and this caudal part, this is the anterior septal angle. Okay, and this is the mid septal angle. And where is the posterior return? That is the posterior septal angle. Clear? Okay. Now this is the upper lateral cartilage. This is the upper lateral cartilage. This is the medial end, and that on either side this is the lateral end. Okay. Bony pyramid we already discussed. This is the keystone area. This is the keystone area. On the keystone area, like yesterday we discussed, this have relationship like this. This distal part of the nasal bone and this proximal part of the upper lateral have like this. So this anastomosis in this area is maximum around 9 mm. That's why this upper lateral cartilage get maximum support from this one. So we always maintain integrity of this one. Okay. Section देना. So this is about, I think you clear your anatomy, forceps. Now after the exposure, like in lecture we discuss, analyze the septum. This patient basically have a bump on the nose. Okay. So we have this axis part of this one. So axis part of the cartilaginous part, axis part of this bony part. Okay. So before to harvest the septum, we excise this part, and this patient have this part is axis. So we excise this part also. 15 number blade. Battery change करो हाँ. So how we excise it? Like we hold this one, you hold this one. Yes. Tooth forceps. So we excise the cartilaginous part of the bump. First we excise this one, then we deal with the bony by rasping. So this is the incremental hump reduction, not en masse entirely. Okay, leave it. ये लेटर वो लगाओ वाइट डबल प्रोंग रिट्रैक्टर. Yes. So we have this axis part. Okay. Now the question arise in your mind, then how much we exercise, okay? So it's the aesthetic analysis of your eyes, then how much we exercise, okay? We keep your photograph in your mind, your then how much we exercise. Now we harvest the septal cartilage and we just create a L strut, okay? Then around the marker dena around 1.5 centimeter superiorly and 1.5 centimeter anteriorly. So we can mark like this, okay? So just we make a incision, दिख रहा है आपको उधर से? And then not acute angle, we just rotate it like this, and now then you can one prong of your this retractor just like this, okay? Forceps देना, suction, 15 number blade. So superiorly we detach, anteriorly we detach, but still posteriorly we attach. So give me the, नहीं ये नहीं वो देना, stores periosteum elevator. So this is the sharp instrument, that is the good instrument. So just we go posterior, come anterior where the bony part is end, and at the junction of this, like just, can you see, look that, like this, okay, like this, like this, because still the inferior is attached. 15 number blade. So rather than we create the L strut, we create the U strut. When you create the U strut, then you have a better foundation, okay? So just cartilage holding forceps. This is the another good forceps that for holding the cartilage. So you just go down and then check it. If you feel resistance, then still you detach it. But if you find it's good, then you remove it. So we have this septum. In septoplasty, we keep in small pieces, but in the rhinoplasty, you can remove it as much as possible because we need for the reconstruction, okay?
ethmoid bone का
ये एथमोइड है,
तो
ये
from
पीपी
where do we
प्लेट,
fraction
ये
process?
आइडियली अपन यहाँ से ही करते हैं, बट बहुत बार ये वीक है तो ये अपन ने ले लिया. Again you try whatever amount of the cartilage you can harvest as much as possible bigger. टुकड़े में नहीं निकालना है ना, जितना निकाल सके अपन. Forceps, ये ये look that I show you the anterior nasal spine. वो देना. This is the anterior nasal spine. You can feel it, Manish, by your finger. This one, okay. So suppose our septum is on that side or on that side, then we completely free, and then we refix in the midline. But I think in this case there is no need, because this is the anterior nasal spine and that is exact on the midline, so we not separate from this attachment. Got it? So now we complete the which golden step? Third. So we move for the bony pyramid modifications. तो इसमें क्या पैक डाल दो यहाँ पे, नेजल स्पेकुलम देना एक बार. You always check the either side of nasal cavity. Packing forceps. Action. So on either side we have a good nasal cavity. पैक दे दो. इधर भी दे दो. छोटा दो यार, छोटा, इसको काटो. So we pack on either side. On this side, so just the support septum on either side also. On this side, so now for dealing this bony pyramid, because this bony pyramid little bit over wide and have the bump. So before to the osteotomy, first we correct the hump on the nose. So either you can rasp the bump by, you can rasp by the powered instrument also. So because you have a big bump, so we use the powered instrument. Okay, तिल लगाना. And मेरे को 15 नंबर देना. Before the rasping, we just go the subperiosteally. So for the subperiosteal, you make a incision by the back end of the knife like this on either side. Joseph periosteum elevator. This is the Joseph periosteum elevator. Okay. So just look that this is the bone. Now we are the subperiosteal. Okay. You never rasp on the periosteum. You just go the subperiosteal. So a patient be less edema later. So I just expose my just you have a like sound. Okay. First on either side and then I attach on both sides. Okay. Hear the sound? रेस्ट दे देना मेरे को एक बार. इंस्ट्रूमेंट गिर गया, कोई साइड एक्स में डालो. I use this one for, but just for your practice. Then how we rasp it? Then this rasp have Medicon rasp. One is the coarse end, one is the fine end. Okay. So how we rasp? Then we hold it like this, and then we hold by the index finger and thumb, and just we pass. Okay. and then we rest, but not on this one, otherwise hours completely. Okay, so look that, and then you do that, then just like you use this movement. Okay, yes, you do the practice. Yes, you hold, and only on the bony vault, only on the bony vault. Yeah, you have this movement. Okay, so first we do by the course, and then fine, you come, and after the rasping, these bony dust you clean it, and by irrigation also. ऐसे पकड़ना है, you just like this. ये look that this finger, because this is the guiding finger, and look that like this, and ये यूं रहना चाहिए. ये look that मैं कर रहा हूँ, लेकिन ये यहाँ पे नहीं है, on the bony pyramid. अगर हमने यूं किया तो सेप्टम पूरा नीचे आ जाएगा. Okay, just rasp it, just rasp. So this is the way by which you can rasp the bony pyramid. Okay, लो voxel periosteum elevator. ला बोला, एक वो लगाओ यहाँ पे. This is the suction and elevator both. This is very good instrument by the Abdul Goksel, a Turkish rhinoplasty surgeon. और लगाओ अच्छे से. यस, आ रहा है उसमें, उसमें आ नहीं रहा. यस, ड्रिल नहीं चल रही. सनोवर, चेक करो ड्रिल ड्रिल. With the different type of the bar that you can use. उस वाले में नहीं लगा एंगल में, ये छोटा है. डायरेक्ट मत कर, डायरेक्ट मत कर.
दूसरी बार लगा मतलब वो मशीन
दूसरा लगा दे यार. You can use like sometimes when you have a over wide bony pyramid, then if you want to remove a strip for the narrowing of the bony pyramid, then we call the osteotomy, because sometimes not usual, but sometimes we need. But it's not necessary, then you can use, but then once you do the more and more cases, then you can use mostly. Otherwise by the rest is good, but sometimes when a big bump, then it creates a problem. It will take time. लगाओ लगा लगाओ. नहीं है अभी इसमें, ये फुट पेडल तुम्हारा काम का नहीं होगा अभी. अभी दूसरा देखो,
स्पीड कम करना.
थोड़ा सा स्पीड कम कर दो भैया. बस इसका हेड एंड नीचे जा रहा है, थोड़ा सा ऊपर चाहिए. कुछ लगाओ नीचे सनोवर. यस, बस ठीक है. यस, नाउ इट्स गुड. So we just rest the bony pyramid. जो जब लगी उसको एलिवेट को देना. We expose completely on either side. जाओ ये उधर रख दो. So we just rest it. But it should be gradual. लाओ भाई ला. So this side more. थोड़ा सा इधर और चाहिए. So basically this is the rhino structure. We just rest the lateral nasal wall also. Now we just check. Still we have. So how we check? Just as the parallel to the nose. Okay, just like this one. Still we have in this area. This one. Okay. Just we rest it. You can use the piaggio also, but will take the more time in the piaggio. A bit more. This one. So you top. No, no. No. Puro. So almost we correct the bump. In the last, whatever small amount we excise in the letter. So we want to reduce now this pony bass speed. Okay, we want to reduce this one. Nasal speculum dena. So because in this patient already we rasp the dorsum. Dorsum is almost open. So no need to the medial osteotomy. We do the lateral osteotomy. For the lateral osteotomy, like we just go by internal lateral osteotomy. So in internal continuous lateral osteotomy, the important thing where you make incision, like the anterior end of the inferior turbinate. Look that this is the inferior turbinate. Okay, you can see on the
Yes.
monitor also. This is the inferior turbinate. Okay, so just on the upper end of this anterior end of the inferior turbinate, we make a 3 mm incision like this. On this side also section dena, because where you engage the osteotome, that is the important thing. If you make this incision in this is the lowest part of the pipe, inferior turbinate, then you just low. If you go here, that is the high. Okay, because for engagement of the osteotomes. Okay, so we have these two different type of the osteotome. This is the for the right and another for the left. This is the guarding end of the osteotome. This is the cutting end of the osteotome. Okay, the guarding end that always outside. Okay, cutting end that is the inside. So how we put it, like this, like like this, because ये look that ये bone है, ये bone में यूं फंस गया जाके, we scrape it and then we hold like this. Okay, at around the 70-degree position, not like this, and then we go gradually down. Ask to your assistant, you use the tap 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 tap, not like tap 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 tap. Okay, and throughout we feel this one, we feel this one. So look that Okay. So look that how we tap 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 tap, and you feel where you are acting. Sometimes in a young male patient, when this lateral nasal wall is too thick, then this osteotome is displaced. Okay, because in the mid part of the lateral nasal wall, the thickness is greatest, maximum. Yes, tap tap. Yes, tap 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 tap. Stop. So once you come to the parallel, then you change your grip. हमने अभी यूं पकड़ा. Now like this. And where exactly you can see, I think in this one, वो देना periosteum elevator, section देना. You can see, I think in this one, if you put a retractor here, section करो. I'm tap 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 tap. Stop. Manish, you can see my. You can see. रुको मैं दिखाता हूँ. सेक्शन करना. You can see. देखो. This is my. This is my. This is my. Okay. This is my osteotome. This is my osteotome. Okay. Now tap tap. I am just on the middle part. Tap tap. रुको. Now you feel something. You feel guarding end. Feel or not? Not this one. This one. Yeah. So now yes. Tap 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 tap. Yes. Tap tap. What is the upper limit? Intercanthal line. Intercanthal line. Tap 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 tap. Once you reach at the intercanthal line, then just you rotate like this. Yes. Tap 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 tap. You now change the sound. Okay. So I am just almost here. थोड़ा सा और मारना है एक बार. बस. So now on the left side we rotate it in the anti-clockwise manner. Now you feel by your hand the bone is mobilized, the bone is break. Okay. Now same on this side, like we just engage it like this, and then इनको देना. You just tap tap. Yes, tap 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 tap. Now you sleep. स्लिप हो गया. हाँ, से स्लिप हो गया. लुक दैट. स्लिप हो गया. बहुत बार स्लिप हो जाता है तो उसको वापस लगाना चाहिए. टैप टैप. यस. टैप 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 टैप. यस. टैप टैप. So now I change my grip like this. This should be like this, not like this or not like this. Okay. Yes. 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 Tap tap. Need more. Tap 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 tap, tap tap, tap tap. Yes. So now I almost at the level of the medial canthus. Now on the right side, I rotate it in the clockwise manner. You feel by the gently hand. Now laterally this bony pyramid is mobilized. You feel from here. Okay. Now the nose is narrow. Okay. Budena bone mobilizer. Cold saline. So we free this lateral nasal wall from the inferior attachment, and now we have the narrow nose. So like it's not necessary then each and every case we use the whole osteotomy. This depends, like if this is a crooked nose then we use the intermediate osteotomy. So it's the depend on the what my patient have the deformity. But within a cold saline. So then for the hemostasis you can put the cold saline for some time. So we complete the which golden step? Fourth, fifth and sixth. Now we move to the next. Okay. Odena cartilage. Up now for the fifth step in this case, uh, either we just check if there is a need or not the spreader graft. If we discuss regarding the indication, if your dorsum is deviated, my dorsum is not deviated. If you have a inverted deformity, we don't have the inverted deformity. If you have a previous existing internal nasal wall insufficiency, my patient doesn't have the complaint regarding a internal nasal wall since. Only we have a one for getting the good dorsal aesthetic line. You can use the spreader graft in this case. 15 number देना. So how you carving this one? This should be before the carving in your mind that मेरे को क्या क्या बनाना है इसे. But if you cut it once, then it create problem. 15 number. First you deattach this bony part. Okay. पकड़ो. So we just thin it because the septum is too thick and these all pieces are useful. हाँ मिलना है आगे बेटे गया पानी वानी तो नहीं पिया चल आ रहा हूँ hold this one you purchase this one this is the Medicon grade this is very useful I think you no need this light I think your eye is good now but I need now this one.
Mm.
This is the 2x lens in this. This is good.
I was in one conference of this. They were selling for 12,000 rupees.
Yeah,
12,000.
the Medicon instrument is
They
a
were, I don't know, some.
little bit costly instrument. राजवीर आप राजवीर तुम्हारे से मिले? Is Dr. Rajveer. He's my consultant. He's a renowned otologist. All rest of surgery is my pillar. नेक्स्ट केस उसको करके फिर डा करा लेना राजवीर. हाँ हाँ. उठाना एक बार. सेल्फ रिटेनिंग लगाओ. When you have a big bump, when you have a excessive caudal part of the septum deviated, then skin is let us shrink because we excise the inner volume. So like skin is like this. So on this skin you can excise, but in this skin you can't excise. But later it's settle down. Lateral crura retractor लगाओ बेटा. Suction दो, irrigation दो. Forceps, forceps. इसको डालो उधर. ये पकड़ना. Suction, seizure, sharp seizure. ठीक है. वो देना ग्राफ बड़ा वाला. So because this patient have a droopy tip. Okay. Uh, so we want to just correction of the rotation. We need projections. Okay. So we use either the columella stud or the septal extension graft, but we have the adequate amount of the cartilage. So we use a big piece of the cartilage, and there is no need to more cartilage use. So, because there is no need to the this spreader graft also in this case, so we use the big piece of the cartilage for as a septal extension graft. थोड़ा इसको लगाए एक बार. Septal extension graft, like yesterday we discussed, is a very different versatile graft, because sometimes the problem in the septal extension graft, we just get a unwanted effect. If I fix this graft, look that like this little bit, then my nose is over rotated. If I fix it like this, then my nose is droopy again. So the important thing then, first when you fix it, then you change the margin of this one. This should be on the both sides, okay, and this should be straight, not like this and not like this. And if you want to the lengthening of your nose, if you want to the reduce the length, then all you can do by this small piece of the cartilage. Okay, suture, needle fixation. So we pass a needle from this side to this side. 4 OPDS. Give me the 4 OPDS. 15 नंबर दे दो मेरे को एक बार. टूथ फोर्स सब दे दो. चलो बाद में काट लेंगे. So when you fix the any structure, then you use 4 OPDS suture. Okay, just from this to this. Yes. So this is the horizontal mattress suture. Always use 3 double knot, like जैसे मैंने बताया था ये, this one, like this one. Cut it. But you can use the columella strut also. It's not necessary then, because if you initially in the beginning you can use the columella strut also.
ये septal extension graft.
This is septal extension graft. The indication of the septal extension graft, when you want to significant projections, you want to the reconstruct your distal part of the septum, then you use the septal extension graft. The ideal length or height, that is around 20 millimeter and the 25 millimeter height, but according to the need you can change the height and the width of the graft. This is a big piece of the cartilage, we cut it later. Because in rest we no need more reconstruction, otherwise sometimes if you have a lateral stud graft or whatever, then according to is just first. What patient you have in your practice mostly?
Autology, ear के लिए.
So how you start the love to the rhinoplasty? कैसे लगा कि मेरे को rhinoplasty सीखनी चाहिए?
पहले जब शुरुआत में 4-5 years back साथ में एम्स में होता है वो राइनोप्लास्टी रिसेक्शन वर्कशॉप भी हुआ था.
Okay, 15 नंबर.
और मैं जॉब में थे, टाइम मिलता था तो वो कर लिया. फिर एक इंदौर के अंदर में भी सर गए थे, ब्रजेंद्र सर है ना उनके वहाँ भी.
डॉक्टर ब्रजेंद्र बसेट सर.
हाँ, वहाँ तो फिर उसके बाद एक्चुअली क्या केस भी करना शुरू किया था, बट प्रॉपर गाइडेंस नहीं मिल रहा था. वहाँ ग्रुप वगैरह नहीं था, फिर थोड़ा सा इसलिए बीच में फिर डिमोटिवेट हो गया था. अभी वापस थोड़ा फिर पेशेंट आते हैं हमारे बीच बीच में
हाँ,
राइनोप्लास्टी के लिए.
पेशेंट सब जगह होते हैं.
हाँ, और कोई कर भी नहीं रहा है तो
हाँ, नहीं,
गुड थिंग, मतलब ईएनटी सर्जन को करना
इसे
चाहिए.
पकड़ना. हाँ, करना चाहिए.
हम्म,
बिकॉज सेप्टम तो यूजुअली हम करते ही
करते
हैं.
हैं, राइट.
लो suture. In your practice, what patient you have mostly? Otology?
ये तो अभी तो जनरली चल रहा है सर, बट
Generally,
आई
chalo.
एम इंटरेस्टेड ओनली इन टिम्पैनोप्लास्टी, सेप्टोप्लास्टी, लाइक टॉन्सिलिज्म, एडिनोइड्स.
Definitely, as a ENT surgeon, we have all types of the patient.
एक टाइम के बाद सर वो क्या सैचुरेशन में आ गया, फिर लगता है कुछ और
Yeah,
करें. मैंने
exactly.
ये करता था, मुझे 3 साल से ब्रेक लगी, सो आई वांट टू रिफ्रेश एंड स्टार्ट अगेन.
पेशेंट तो क्या आने लग जाते हैं वही.
राइट. मेरा कुलीग है वो बहुत ज़बरदस्त है सर्जन, वो इनका फ्रेंड भी है, डॉक्टर संदीप का,
क्या नाम है?
डॉक्टर इम्तियाज काजी.
ओके.
वही शिफ्टेड बैक टू कश्मीर ना. पहले
ओके.
सऊदी था, इंग्लैंड था,
हाँ हाँ.
उसके बाद कुवैत रहा वो इतनी देर,
कट इट.
और बहुत देर बाद वापस आया,
अच्छा.
अराउंड 20 years. ही इज़ वेरी गुड एट
ओके.
इट. अपर लेटरल cartilage पे
So we
कुछ नहीं है
suture.
ना.
Yes, we suture the upper lateral. Whenever you rest the bump, never do the overwork. You can do the later also if you feel realized, but you never overdo. Sometimes if you have a excess upper lateral cartilage after the rasping of the bump, then these margin you can you can just rotate it inside the spreader flap. Okay. काटो. काटो. Mostly suture used in the rhinoplasty, there is a 4 OPDS, 5 OPDS or 6 ovicril rapid that usually for the closing. Tooth forceps. अगर पैक नहीं है ना. Why double prong retractor? Needle, tooth forcer. So what's the name of this that I am doing this?
Tangent group.
Yes, yesterday we discussed. Look that if we advancement this medial crust on this native septum, that is the tongue in groove. But if you reconstruct the septum anteriorly and then you advancement of this medial crust, that is the modified tongue in groove. So this is the modified tongue in groove suture. This is the modified tongue in groove. So how we just suture, ये फोर ही है ना, tongue in groove and the modified tongue in groove, both for increased projections and also for reduce the infratip column
मॉडिफाइड
energy.
का क्या डिफरेंस है?
मॉडिफाइड का डिफरेंस ये है ना सर, बेसिकली अगर ये जैसे हमने इस पे सूचर कर रहे हैं,
हाँ जी।
अगर सपोज करो ये हम नहीं लगाते और जो इसका सेप्टम था उस सेप्टम पे इसको करते, तो टंग इन ग्रूव, क्लासिक टंग इन ग्रूव, टंग इन ग्रूव, that means the tongue is the caudal part of the septum and groove between the medial crust. This is the tongue in groove. 15 नंबर देना. So just we pass this suture from inside like this. सक्शन करना एक बार, आप मनीष सक्शन ले लो. यस, यहाँ पे करना है. यस, यस, this and then again we pass from this side to the another side like this. आ गया निडल में. Yes, and then because we have some little bit injury, so just we from the inside. Yes, so we prepare this one also. केस इसको इधर से निकालना होगा, इधर निकालो इसको. Yes. So now the note is inside, huh? Note is inside. Cut it. Otherwise, this note feel by the patient. Tooth pusher. Again, these are the horizontal mattress suture. So the entry and exit of this needle, that should be same level. We fix, always we pull it along the longitudinal, not like this. Okay, cut it. मेजरमेंट का देना. We have this little bit axis of this lateral crust, so we just little bit excise 15 number blade, little bit cephalic trimming, tooth forceps. So just we make a step here. So in the cephalic trimming, how much you excise, that is not important. How much you preserve, at least 10 we should need. Hmm. So look that tooth forceps देना. The scroll area is this one. That is the shape. Huh? Yes. 15 number blade. हाँ हाँ बोलो. 15 number. Suture. So we use the now the dome creating sutures. Okay. इसमें वैसे ओवरऑल अगर आप देखोगे तो ये बहुत ज़्यादा वाइड नहीं है. नहीं भी यूज में लो तो भी चल सकता है इसमें. जस्ट फ्रॉम पकड़ना इसको like medial to lateral and then lateral to medial. ये तो अभी मेडिकल कॉलेज भी हो गया ना पाली में.
हाँ तो
वहाँ कोई है प्लास्टिक सर्जन? कट इट.
वहाँ सर वो जोधपुर एम्स में पहले जो एहसास थे डॉक्टर गौरव कटारिया वही
अच्छा
वहाँ अभी संभाल रहे थे वो, लेकिन वहाँ तो पाली जो जिला अस्पताल है ना वहीं कर रहे हैं
अच्छा अच्छा
सर्जरी बांगड़ हॉस्पिटल जिसको हम बोलते हैं।
अच्छा अच्छा.
वो उतना इंफ्रास्ट्रक्चर अच्छा नहीं है वहाँ,
हाँ
फैकल्टी
बिल्कुल
नहीं है कुछ भी नहीं।
टाइम लगेगा उसमें.
तो सिरोही में भी खुल गया पिछले साल।
पकड़ना.
सिरोही में भी सेकेंड ईयर बैच अभी चालू हो गया, एवरी डिस्ट्रिक्ट में ओपन करेंगे आपको।
क्या मतलब है यार? छोड़ो. How many seats there?
सीट्स तो
Section
150
करना.
अराउंड है, लेकिन जैसे फॉर एग्जांपल वहाँ जैसे अभी पीजी की सीट भी करी है, रेडियोलॉजी डिपार्टमेंट लेकिन कोई है ही नहीं, प्रोफेसर ही नहीं है वहाँ की। जो सोनोग्राफी रिपोर्ट्स आती है ना, मतलब उसमें तो बड़ा केस हो गया सर मुझे कुछ दिन पहले। मतलब एक पेशेंट का वो किया था कैंसर सर्जरी,
Okay.
तो लेटर ऑन क्या हुआ कि पेशेंट की डेथ हो गई, तो उन्होंने कहीं सोनोग्राफी कराई थी,
Section. Oh.
उसने बोला कि पेशेंट की किडनी निकाल दी डॉक्टर ने, इस तरह का एलिगेशन है। क्योंकि जो
Oh.
पाली के अंदर जिसने सोनोग्राफी करी ना, उसने गलत तरीके से बोल दिया, आपको दिखा नहीं कि किडनी इज एब्सेंट। बहुत बड़ा
सही.
हुआ था सोशल मीडिया में, फिर बाद में जाके कुछ नहीं, वो मीडिया की गलती थी, डॉक्टर का कोई पोस्टमार्टम थी पता करना, उससे पहले तो ये लोग पूरा सोशल मीडिया में सब जगह फैला दिया कि किडनी निकाल दी। जस्ट वो एक इतनी घटिया
Plus.
रिपोर्ट सोनोग्राफी प्लेन पेपर में, कोई डॉक्टर के साइन वगैरह कुछ नहीं हुआ। पाली में ऐसे फिर उसी से हमने सोचा कि रेडियोलॉजी डिपार्टमेंट में क्या होता है फिर वो।
Now for the bug problem आती है. So this is the
राइट सर।
interdermal suture. We just connect. कुछ 4 हो देना चाहिए था यार. Cut it. This is the dome equalizing sutures. Just cut it. Foro देना. Give me the foro. Clean करना. After the removal of the bump, the skin shrinks because this is the excess skin. और वो देना bone mobilizer. Dry pad. So the dorsum is equal now. वो देना. Bridge retractor. So we just check it. लाइट यहाँ उसको वो ना लाइट, ये लाइट यहाँ कर दो यार. ये सेक्शन दो. हाँ यस थैंक यू. सेल्फ रिटेनिंग लगाओ. ड्रिल दो. So we just rest this axis part for better contour. For dorsum smoothing. Yes. एक आपू बनाओ डाइस्ट
राइट में
4O acryl. So this suture, that is the quilting suture section. करो मैंने. Just from anterior to the posterior and the top to bottom. So for reduce the dead space. 4O acryl. 4O acryl. Okay. उसको पकड़ के रखो उसको सही. So this suture you put from top to bottom. Why? If you go from bottom to top, and if you go from top to bottom, then if you have any collection that comes down. Okay. Yes.
First one was inside there.
Hmm?
First one inside that operated area.
What is it?
Entry to posterior.
Anterior to posterior, like first go anterior to posterior and then come.
Yeah. The first suture we gave you that caudal area.
Yes, caudal area.
Now this is like through the mucosa.
Yes.
This will remove later on.
You can remove. Usually there is no need.
Okay.
Vitral is absorbable suture, just like you use in the septoplasty. But sometimes if you patient feel, then I feel something not.
पैकिंग की जरूरत नहीं पड़ेगी.
हाँ, मैरोसिल की जरूरत नहीं है. छोड़ दो. लाओ. Cut it. 6O. So in the last, he make it the diest. So these small piece just to camouflage or where you want to something, then you can use. So this is the 6O acrylapid suture. When we close it, then first just at center part, just three double knot, cut it, then second suture on either side of first like this, or you can use the corner suture, cut it. Now this is the third suture. Okay, you use this needle holder particularly for the 6O acryl. Then now the corner suture. So for the corner suture, like this, cut it. Now on this side, this is the last fifth suture. There is no need to like the hold by the forceps to the skin, otherwise you have a scar on the. Cut it. Small retractor. So for closing of the marginal incision, just like, and when you close the marginal incision, just only the margin to margin, not you not pass through the cartilage. On this side, two suture, that is enough. One on the middle part, cut it. When you close it, then we face little bit difficulties because we usually not used to for this 605 ovical suture. Irrigations, cleaning, cut it. उधर रख।
स्टिच कटिंग के टाइम भी स्पेशल इंस्ट्रूमेंट चाहिए होते हैं क्या?
शार्प सीजर चाहिए होती है।
हाँ वो भी बहुत छोटा है।
शार्प सीजर चाहिए होती है और कुछ नहीं।
अंदर के भी सारे रिमूव करते हैं कैसे?
हैं?
अंदर वाले भी रिमूव करना सारे बाइकर के जो हैं।
नहीं नहीं कुछ नहीं, ये तो अपने आप एब्जॉर्ब हो जाते हैं। रैपिड है नहीं, इस द वाइक्रिल वाइकिल में भी रैपिड है ये। सो दैट इज और प्रीवियस इसको इधर लाना। So we have this bump now. Now the bump is gone and the nose is rotate superiorly. Nose is rotate and we decrease this columellation also. Now prepare किया, डालो आप डालो फटाफट दो। So basically we follow all this. This is the basic steps.
Yes sir.
है ना? So you all follow this all basic steps in each and every case. Each and every case. Maybe if you have a bony more deformity, then we use the other more osteotomies. You can use the spreader graft if you have a mid vault like the deviations, or you can use the same work by the you. That will take more time, but you can do by that one. You can do by that one. If you use this one, then you use this different type of the burr, not routine burr. Otherwise, sometimes the cutting but the avulse entirely gone.
This is only for hump reduction. This sir.
For hump reduction or for the rhino sculpture, if you have a very thick nasal bone, lateral nasal wall, and it's very difficult to do the osteotomy, then you just first thin that,
Right.
and then you can do the osteotomies. Rhino sculpture, that we call the rhino sculpture. Rhino sculpture. And additional advantage when you have a minor bump later and just for the rasping of the margin, just like in the last we do the septal extension graft part. So then you, because we have the thick skin patient, we have the advantage, but some if you have a thin skin patient, then definitely if you have a like a small graft or something, then you have the problem. In such type of the case, when a patient have only the bump, no functional complaint, then they are easy case because there no need to change the dynamics of the nose. The problem in the crooked nose or like another patient that have a tip deformity. In that case, we change the inner framework. So in that case, they are little bit difficult. In the bump excision, that is the issue.
कभी कभी फिर यहाँ से जब वो फर्स्ट स्टेप में उठाया था ना स्किन,
हाँ
स्किन के एकदम पास से अगर डिफेक्शन हो जाए तो बाद में यहाँ थोड़ा ब्लैकनिंग भी होता है बाद में स्किन का,
हाँ,
उसका
यहाँ
क्या
पे क्या है,
करते हैं
ये
सर?
डैमेज नहीं होना चाहिए, ये पार्ट यहाँ पे इंजरी नहीं होना चाहिए।
काफी बार जैसे स्किन, अगर स्किन के पास में अगर स्लैप अगर पहुंच जाते हैं तो थोड़ा सा स्किन का पार्ट ब्लैकनिंग भी,
नहीं,
ब्लैक थोड़ा
ब्लैकनिंग तो नहीं होता अनटिल
नहीं
अनलेस
होता
कोई
है। ओके,
ब्लैकनिंग नहीं होता।
राइट।
बट जैसे सपोज करो आपका इंजर हो गया, डैमेज हो गया, तो उसको रिपेयर
रिपेयर,
करना चाहिए।
हाँ।
नेवर यू छोड़ना नहीं, उसको रिपेयर हमें करना चाहिए। लाओ भाई लाओ, इसमें डाला है, पानी निकाल लिया। The same work you can do in the 1 ml syringe. So you just pass from this space, just like go like this, and just where you want. Then you can, so just for, suppose in the last where you have the depression, then you can use. मुकेश, नीड नहीं है अभी और, नीड नहीं है और, नो नीड, नो नीड। Now, so this is the gelonate. What's this is the gelonate. This is the sofratuli. So look that how we make. Packing for सब देना।
ये तो देखा हुआ है।
हाँ, ये बर्न ड्रेसिंग में काम में
सुप्राटोलिया,
लेते हैं, यस बर्न में काम में
बॉन्ड,
लेते हैं।
ये तो जानवर को हुआ
गिव मी द
मैंने
नेजल
यूज,
स्पेकुलम, कोई पैक वैक चेक कर लो मेरे को, नेजल स्पेकुलम देना भाई। फेस का सेक्शन दे देना, फेस वाला देना। बिकॉज समटाइम्स द पैकिंग विल लीव। दो, वो नहीं है। हाँ, स्प्रिंट देना। दिस इज द स्प्रिंट। This remove on the 10th day.
10th.
Suture. Cut it, Manish. Yes. Now packing forceps. This one. So just we put sometimes I demonstrate in the workshop or conference, then everyone asks me, you put the packing, you put the Marocel. Patient bleed. Why unnecessary bleed the patient? If you are not in the right plane, then you bleed. ला भाई ओके छोटा और दे देना दो just on under the marginal incision for better approximation. Love, steady strip, steady strips. First layer of steady strips. First, that is on the center, then the next half on the interior, like this. Next, ये तो दे दो. Whole girl patient like this one because the white is this is not visible. POP. So you not cover this part just to release the edema.
Yes.
I never use on the forehead. Okay, some people use on this also. No need to use. So this is 6 layer POP. You ask the patient just for the post-op because you have maybe the bleeding because once the plaster is you have some edema or some blackening around the eye sometimes. So again, but this is little longer than earlier. Yeah. So day after tomorrow, when we remove the yellow nail, then we remove this one, and this we remove on the 10th day. Thank you. The simple case, but it's okay. And here, huh? And here, huh? No, 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 no. Okay.